Hi, everybody. It's Karen Anderson here with Aortic Hope. I'm sorry I'm late, but I had to have my doctor's appointment with Dr. Stacy Fisher, my cardiologist, who's with us today. So a survivor is always a patient somewhere. I guess you can be a patient sometimes, but this survivor is still a patient. So I had to fit in my appointment. But I'm sorry that we're late, but we're here now. So hopefully you guys will start to join us. And with this format, we're just going to talk for a little bit. And if you have questions or topics or things you want to talk about, just type them in the comment line. If you'd like to ask a question and you want it to remain anonymous, then you can send a message to Aortic Hope and someone there will type the question for you. So we're just going to jump right in and get started tonight and talk about all things cardiology. So, one of the first things I think I'm going to ask for a lot of the new survivors or patients that are online is, what is the role of the cardiologist? So some of us, a scan happens, you find an aneurysm, or you've had a dissection. What's the role of the cardiologist in your care?
So the role of the cardiologist is really a partner in your care, trying to, number one, figure out why you had the aneurysm or dissection. Mm-hmm. Do you have a connective tissue problem like Marfan syndrome or Ehlers-Danlos syndrome? Or do you have really high blood pressure, high cholesterol? What can we do to reduce your risk of extending the aneurysm or getting a new aneurysm in another place? And what do we do to screen you? So what kind of screening pattern should you be on? And do you need screening in other areas of your body, for example, the brain? So there are certain types of problems that can also affect vessels in the brain. And sometimes we're really just looking at the heart and the aorta.
Okay. So it is important to keep your cardiologist as part of your team because you're also going to be the one that's going to handle our medications. It's typically a cardiologist, not the surgeon.
Exactly. So medications for blood pressure, for heart rate, for rhythm issues, screening of the heart with echocardiography, and also really important is screening of lipids. You should also discuss diet modification and interventions with your cardiologist. Do you need a low salt diet? There are some people with actually low blood pressure that need more salt in their diet.
That's a really good point. We were just talked about that last night, and somebody had asked, or the other night, are there specific diets? And I guess I never even thought everybody just goes to low salt, but that's interesting. There are people that might need more.
Right. So we are 60% salt water as humans. So that's actually really, really important, but it's a balance. So it depends on how your kidneys excrete salt and how much salt you're taking in. Some people are very salt sensitive where in order to have a reasonable blood pressure, they need no salt in their diet. And some people actually need a little bit more because they have low blood pressure.
Okay. So that's a good question I have right now, popped into my mind. So in a moment, because we all tend to fluctuate, not all of us get to have the perfect blood pressure that stays the same, but if somebody does go into a low, would you recommend then that they maybe go eat something salty?
Yes.
Okay.
And if you overdo it with a water pill, for example, sometimes with the diuretic, it's not quite clear exactly how strong it's going to be for you. You can always make up for that with fluid and salt.
Okay.
Right, and it'll put it back in your system, and then you're trying to find the right balance.
So if you are running low, would that be an indicator that you maybe are lacking some fluid? I forget the term. What is that called? You're dehydrated?
Dehydrated, absolutely. It could be, or it could be that the medicines are too strong.
Okay.
Or, there's other reasons too. That, there can be very serious reasons like infection or bleeding, that type of thing. You wouldn't want to miss that. But if you're trying, for example, a new blood pressure medicine or new diuretic and you're getting low numbers, then you can make up for that with some salt and water and then talk to your doctor about lowering the medications.
And what about if you hit a high? Could you be taking in too much water? Is that even possible?
So it is possible, but generally adding water and getting rid of salt will help you get out of that high.
Oh, so adding water and salt will help you get out of a high.
No, adding water and no salt.
And no salt,
yeah,
but just
really
water.
Cutting the salt out of your diet.
Then you can get rid of the high.
Yeah, so if you really cut out the salt and have like no added salt and low salt choices for a couple of days, you'll find that you're really peeing quite a bit and that you're actually getting rid of a lot of the salt.
Let me ask you a question. While we're still in cold season, we're still in flu season, what would be some of the over-the-counter medications that people can take that have aortic disease that you would recommend?
That is a great question. So the things you really want to avoid are the stimulants and things that can make the blood pressure skyrocket. So you really don't want ibuprofen because that can make your blood pressure go way up. You can take Tylenol unless you have liver disease or an allergy to Tylenol. But otherwise, Tylenol's fine. The ones that are going to be okay are the DM products and the guaifenesin, the thin secretions. That's okay. The NyQuil is generally okay. The things that are not okay would be the Dayquil. Okay. Anything with pseudoephedrine or Sudafed. And most of the things that you can have are labeled don't take with high blood pressure.
So it's right there for you. So Corseed and HBP
is made good, for people
right?
that want to avoid things that make your blood pressure high. So that would be fine. That's one brand.
Okay.
And again, what you're avoiding is the -D or the pseudoephedrine. You don't want the Afrin nasal spray. That can really skyrocket your blood pressure.
So just more the saline mist.
The saline mist is fine. Even the steroid nasal spray is not for a cold or flu, but for allergies are fine. The regular allergy pills are fine, like Claritin, Zyrtec, Benadryl.
Okay.
Those are fine, but not the -D, which is the allergy pill plus the Sudafed. You want to stay away from that.
Okay. That's good too, because allergy season, I've never had it before, and I just had my first bout the other day. It just went on all day. So, but I took my Benadryl because I figured you'd say it was okay.
Benadryl is okay, but none of the ones that are -D.
So one of the things I wanted to talk about was, and I mentioned this to you the other night, is having your family members tested.
Yeah.
So if you discover you have an aneurysm or you've had a dissection type A or B, what family members should be tested and what kinds of tests should they have done, depending upon if they're, let's say, 16 and under, or is there an age bracket? And I know this is not a widely accepted or determined protocols, but what, in your opinion, would you tell a patient to do?
So the first thing is just to talk to your doctor about what is the likelihood that there's a genetic risk of what you specifically have. Because for people that really have bad atherosclerotic vascular disease, you're really screening your family for cholesterol, for sugar, for blood pressure, for things that cause atherosclerotic disease. Okay. So again, if somebody's had a lifetime of high blood pressure and has an extending aneurysm or has a dissection, that's not necessarily something that can't be prevented in other people, but that would be more the traditional risk factors. If you have somebody who doesn't have those risk factors or doesn't have a lot of plaque related to their aneurysm, that's where we're looking for other causes. So some of the people that have aneurysm or dissection might have had a car accident or a deceleration injury. Those are not going to run in families, so nothing for their families.
Okay.
Nothing required. But for somebody, for example, younger, healthier, maybe even flexible, or who may have some Marfan's features, you want to actually talk about your specific risk. And there is gene testing that can look for some of the more common genes. That gene testing is just, can be saline, can be a buccal swab, cheek cells, or it could be blood. And can go to a commercial company and we'll look at the most common genes that can actually cause aneurysm dissection. If you have a gene show up that is causative or pathogenic, your family members could be tested just for that spot on the gene that is affecting you, and they know whether they have a higher risk or whether they're not at risk. So that can be extraordinarily helpful in both ways. So we would recommend first-degree family members get tested, parents, brothers, sisters, children. Okay. So of the people that are positive, they should actually have aortic screening, and they should be followed for aortic disease because they have a gene that makes their tissues weaker, that makes you more likely to be able to have those. Certain genes can affect the brain and other vessels as well. And certain genes really only affect like the ascending aorta or different parts of the vessels. And you can tailor your screening that way. And then you would screen, for example, the children of that person. So if, for example, your sister had the gene that you have, then her children could be tested. Okay. And if they're negative, they're home free. And if they're positive, they get screening and they continue to get screening. the other thing that can be done if there's a gene available is there can now be fertility testing and screening. So eggs or sperm could actually be screened for the gene that can cause disease.
Okay.
And they can be removed so that you could
Wow.
have only your healthy eggs or your healthy sperm given to your potential offspring.
So let me make sure I understand.
You have to
so
do
if you
that
know,
through IVF.
So if you know that you have like Ehlers-Danlos or Loewe Dietz or Marfan or Actor2 or any of the others, if you know, and you want to have a baby, you can do this. It's only done through IVF, and therefore you're ensuring your offspring won't have this
Right,
disease.
so you can
That's
screen
amazing.
just for the disease.
That's
exactly.
amazing.
So, for example, if your son had the same gene that caused was pathogenic for one of these syndromes that cause aortic disease, even if he didn't have the aneurysm or dissection, he could have sperm screened that the sperm that carry that gene removed.
Okay.
The sperm that don't carry the gene used for fertility.
That's amazing.
And then he could have his own children, his own genes, but without the one that actually can affect the offspring. So that is generally available through fertility centers now. They can also do, and I'd highly recommend if you're going to go through the effort to do that, they can do like a preventive genetic screen on the sperm or eggs and look for genes that are known to cause cancer or cardiac disease. And those can be taken out and the healthier ones chosen. So we don't know all of them.
Wow.
So you're not guaranteed like purebred.
Right.
But you are guaranteed that you're not going to pass on this aortic dissection gene to your kids.
So what about...
If you can do that. So now not everybody has a gene that we know.
Right. What about the rest of us that don't have one?
So the rest of you that don't have one, but also don't have like definite atherosclerotic gene that's passed on, we would recommend imaging to parents, brothers, sisters, children, and then to anybody that's affected, their parents, brothers, sisters, children.
So at what age? So for instance, I came to you 5 years ago, but my son was only 15, and I don't think we did an echo. I think he had his retinas checked, but at what age do you think, okay, this is when they have a test?
So there isn't a clear recommendation. We sort of look at the age of the person that's presented. Honestly, if you have a dissection in your 30s, 40s, really as soon as we know about it, it's reasonable to have screening of the kids. Some people will take 5, 10, or 20 years below the age that somebody presented at, but there is not a consensus recommendation in the communities.
Okay.
So usually we talk about, the particular people that are affected. What is their sensitivity with knowing, with not knowing? When do we really want to test? We always want to test before there's pregnancy involved, especially if it's a woman affected, because the stress of pregnancy can cause problems, and a dissection in pregnancy, often the pregnancy is lost. So we like to screen before a pregnancy. Generally, I like to screen people at least in adolescence, and sometimes the biggest changes and the biggest events happen in adolescence because of the growth hormone.
Okay.
So that's
and then what would you recommend? Just doing an echo to avoid the radiation, or would you do an MRI?
So if it's a type 1 dissection, I would just do an echo. And if everything's absolutely normal in the echo, I would probably repeat the echo in about 3 years.
Okay.
If there's anything that we either really can't see, or because echoes can be of various quality. Sometimes people have a chest shape that you just can't see. We often can't see well through breast implants. We often can't see well if somebody has lung disease, like COPD patients. And sometimes it's just purely the chest shape we really just can't see. But if you can see or not. So if the quality of the echo is good and you can see most of the aorta, you're done. If you have somebody who, for example, had a type B dissection, had abdominal aneurysm early, had some connective tissue findings, then you really should do an MR or CT, preferably an MR to avoid the radiation, but a CT is going to give you a little bit better definition.
Okay.
So,
well, now that we're talking about tests, I'm just going to sideline here into another topic that we've talked about. It's brought up often, the different tests. There's not arguments, but discussions within the community about I'm going to have my CT. I just had a CT. Well, why don't you have an MR? What about an echo? Can you talk a little bit about these tests and why one over the other, and what we just spoke about before, how they're shaped differently and why you could have such a difference in sizes between two different types of tests?
Absolutely. So the testing is really important, and it's important that you have tests where the doctors can actually line them up, compare them side by side, and actually make measurements that are interchangeable. So the aorta, if you think about it, and I'm going to show you, this is actually a 3D printed aorta of somebody that's had a dissection. This is real size. So this particular aorta.
But before you say anything, this, I don't think everybody realizes that this is the real size of your aorta. Like, I don't think anybody realized how wide in diameter this actually sits, like however it sits in your chest.
So let me show you how it sits.
It's amazing.
So this would actually sit like this.
That's so cool,
right?
Big, yeah.
So this is actually where the valve takes off. So here would sit in a chest of someone a little bit bigger than me.
Mm-hmm.
But this is actually an aorta, and in this part you can see there's aneurysm where it bulges. This person had a dissection and essentially had extensive reconstruction. And you can even see stenting within the aorta. This is actually printed from somebody's MRI scan and printed on a 3D printer with resin, like a resin texture. And these are done when we need to really look at where the side branches come off, where we want to look at the exact size and shape of what's inside. It may help with surgical planning. It may help with positioning of material. So it can be a new technology that we're really learning how to use to improve outcomes and to improve some of the non-surgical approaches to working within the aorta. So we've done these on patients where we're really doing planning. This is not something that can be done during an acute type A or type B dissection, because it takes a lot of time to get the scanning. To do the sequencing may take 5 or 6 hours to actually manipulate the images to get the level of definition and the angles that we want to decide where we are going to pre-cut these pieces so that they print, so that we can actually look at them and understand them, to make sure that these side branches that we want to see are going to show up. So it can take a long time, and then it takes about 10 hours to print, to physically print, and then there's some post-processing just to make sure that the material isn't going to just shatter.
So what's the size of that typically?
So this one, we can measure it, but this one is about, my thumb is from here to here is about 1 inch. So this would be about 1 3/4 inches.
So if you had an aneurysm, if you had a 5 centimeter aneurysm, how much wider does that go, or is it just a bulge off the side?
This one is probably about 3.5, 4 centimeters, so it would be another centimeter here.
So wow! So when somebody goes in and they discover like a 7 centimeter, you're
that
talking,
would be
this
twice
is pretty big.
Right,
That's
right.
amazing. That's amazing.
And again, when you look in the chest, it's really a lot of the chest space, right?
So how is it that it's not that it's asymptomatic when you've got something in your chest that's so big?
So generally the aorta is sitting unobstructed and has space around it. So the only symptoms you would get from size is if it's pressing something around it.
Okay.
So if it is, it's generally going to press on the esophagus or the trachea, and you may have swallowing or breathing difficulties. You could also get that from scar tissue after something like an aneurysm dissection. But they usually don't feel the size.
Okay. All right. So let's go back and talk about the types of scans. You were going to talk about the tests, right?
So the testing that can be done, number one, an echocardiogram. So an echocardiogram is ultrasound, and it's really ultrasound of the heart. So it's looking at the size and shape of the heart, the vessels coming out of the heart. Generally, there's a picture from here looking down at the arch. So you can actually look down and see this part of the arch and the beginning of the part sloping down. You can measure the size, shape, and speed of blood flow. So if there's a narrowing, this blood actually speeds up, and you see a difference as it gets through the narrow part. If there's a widening, you may see turbulence. You do not see certain parts right where the lung vessels cross. You can't see through air.
Okay.
So you will have patches that you can't see, but you get a really good look at the sinuses where the aorta comes out of the heart and the beginning of the ascending. So exactly where your type 1 happens. You also get a very good look at the valves. So some of the connective tissues will have valve problems associated, and some of the aneurysms will pull apart the aortic valve so that the leaflets can't touch and the valve leaks. So that's the type of thing that we'll see really well. We also see effects of high blood pressure on the heart, and we can measure the pressures in the heart, and we can look for fluid around the heart. So that test is fantastic, specifically at looking at the heart in the beginning parts. Ultrasound can often see most of the aorta, but not all of it.
Mm-hmm.
The CAT scan or MRI is going to be focused and can really see all of the aorta, where the echo is mainly a 2D image and you're measuring an oval. The CAT scan or MRI is a 3D image and it's going to be reconstructed to measure the area around it. Now, that being said, if you look at this aorta, right, every single part of it has a tiny bit difference in measurement. So if I'm measuring a 1 millimeter difference in this, say, 3.5 centimeter tube, there may be a little bit of measurement variability because you could measure either straight across here or you could measure a little bit of an angle, and you're going to get a millimeter or so difference. So there's a little bit of variability. And again, when you measure this, it's not exactly a circle. So you're trying to measure the greatest diameter, but not go too oblong.
Right.
Right?
Right.
So it's a little bit of variability because of that. So what we need is we need to actually put the measurements side by side. Now, if you're going from like 4 to 4.5, that's a big jump. If you're going from 4 to 4.1 or 4 to 4.2, that may actually not really be a difference. And it may be that you want a confirmatory test, or it may be that we want to test, say, 3 or 6 months later just to make sure that it's not continuing to increase.
Okay.
And then you may get the same number, you may go back to 4 because of the measurements. And again, when you look at something where every part of it is a little bit different size, we're trying to measure the same areas and give you the biggest sizes.
Now, why would, and we have somebody who's listening right now, had I can't remember now if she was a scan, I think it was an echo, measured 4.8, and a different hospital looking at the same thing said, no, we measure that at 5.2. Is it, again, just an angle, the way that they measure it?
It's the angle and it's the spot that they're looking at.
So at the end of the day, it's what your doctor's going to measure it as. That's the number that you're going to really go by.
Well, and the radiologist, it should be pretty interchangeable, honestly. You should be able to take a ruler and measure it. Right. But, usually 0.1, 0.2, 1 to 2 millimeters is going to be the variability. Shouldn't be much more than that. If it is much more than that, you may want to take them to an independent reader, especially if it's making the difference of like either a 0.5 centimeter change over a year, which would be enough to recommend something like a surgery, or if you're really in that like 5 to 5.5 range where you're looking at something like a surgery. Now, again, depending on what you have, the recommendations are very different for when we would look at surgery. So, for example, in Marfan syndrome, which is where the tissues are very thin, that is a fibrillin gene mutation. That is something that we do offer genetic testing for. Genetic testing is not perfect for it. It's largely a clinical diagnosis. But there are features that go with this, and the rupture rate is too high, even above 4.5. So in that condition, we offer surgery at 4.5, or we offer surgery to women that are intending a pregnancy below 4.1. Okay, so it's very different. And these are often women that are 6 feet tall, where if you indexed it for their body height, you would actually want to go toward higher numbers rather than lower numbers. But the tensile strength for that person with that condition and that type of tissue is too high. Now, if I have a congenital heart patient with tetralogy of Fallot where their aorta is just bigger because it started bigger, you know, those patients don't really rupture, and we'll let them go to like 6.
Wow. Okay.
And we won't really look at surgery before that because the rupture rate is very low.
So what about somebody who's had a dissection but doesn't have anything genetic? It's probably just a familial. They don't know what it is.
Somebody that's had a dissection has something going on, right? So unless they've had a dissection like from a car crash, where you're looking at the healing around that dissection, the area right around that, but you think they otherwise have normal tissues. So again, it depends on the person, but if somebody has had a dissection for no good reason, you know, they do have a connective tissue problem.
Yeah.
Right?
Yeah.
So you're going to you're going to use the standard recommendations, which is generally around 5. But again, if something's expanding like a half a centimeter over a year, that is 5 millimeters over a year. That's a fairly rapid rate of expansion. You're going to look at that closely. What do you mean? What about no growth?
What if there really hasn't been any growth in a couple years?
Well, that's great.
Just sitting at like a 5.2, which is staying there. Would you still recommend it, or would you still say let's keep watching?
It matters what they have.
Okay.
And what else is there in their family history, and is their blood pressure controlled?
Yep. Okay.
But we definitely like no growth.
A lot of factors. Yeah, no growth.
A lot of factors. We like no growth.
Yeah.
And that's why you need a team. You need a team that knows you, that you're working with. And it also depends on the person. So for example, if I have a 90-year-old, you know, and they're staying really stable at 5 for 10 years, I'm going to try to leave that alone.
Yeah. Yes. Yeah.
So I had one woman who had an aortic valve replacement, and probably because of plaque, she had a tear where the rupture, where the cross clamp had been in her arch. And this woman I adored, but she was in her she was probably 91 when we found this. On her regular echo, she had an expanding aneurysm, and it was about 7 centimeters, and there was some clot around it. And she said, I am not doing anything about it. There's nothing I will do about this. I'm 91. I'm not doing anything about this. Well, when she was 99, she died of other things with a 10-centimeter aneurysm.
That's amazing.
That, you know, had some clot around it, hadn't affected her at all. How that happened, I don't know. She had some luck.
Yeah.
Her statistically, you know, we should have fixed it, or she should have had a rupture, right? Maybe it was scar tissue from around the surgery that kind of contained the tear that she had. She did really well. It's amazing.
Yeah, we've talked about that scan before. I think I saw a picture of it. That's pretty incredible.
It was a scary scan.
Yeah.
And a really nice lady. And she would come in and say, I'm time bomb Betty, and I don't want to scan today. And I'm like, I wouldn't want one either. You don't want to touch it. Let's not do it. Let's just make sure everything's perfect. You have perfect blood pressure. You're eating perfectly. Your attitude is amazing. She went to everything she could possibly go to because she didn't want to miss a minute.
That's the way to live. That's the way to do it. So we know that the echo is going to show more function and 2D, and your CAT scan MRI is 3D. So they're interchangeable as far as size. You're going to probably get the same results.
You should get the same results. The CT, actually, you're going to see the some parts of it a little bit more clearly.
Okay.
The MR, you're going to get the idea of it everywhere, and they should be interchangeable measurements. They may be off by 1 millimeter or 2, the same as any other, because again, even if you're holding it in your hand and taking a ruler and measuring it, it depends where you measure. So inside, this part is going to be a little bit different than inside this part, and we try to go to the bigger areas. But one radiologist or one measuring person may have a different spot, and usually you're just seeing a report. So most people measure right where the aorta crosses the pulmonary artery, the sinuses, the sinotubular junction, but some people just measure the biggest spot. And then unless they exactly say where they're measuring, that millimeter or 2 can be very frustrating for you to read in a report, but may not be too meaningful.
Right. Okay.
And that's why your doctor may say, well, it's 1 millimeter or 2 bigger. We'll have to take a look at the scans. And you're thinking, I'm doomed. and we're thinking, probably measured wrong, right? Or probably measured differently.
I think one of the things we should learn as patients is not to feel doom. It's like when you're on a plane and there's turbulence. If you don't see the flight attendants freaking out, then there's really no reason that you should.
Right.
So it should probably be the same thing with us and with the doctors. If you're like, we'll take another look, we have to find a way to say, okay, it doesn't seem like it's that big of a deal.
Well, and you can even say, do you think it's measurement variability, or do you think that I'm having changes, or can you tell me after you look at it and make a decision? That's okay to do, and it's okay to say, look, I'm really anxious about this. I'd like to have better, good communication about this. I'd like to know what you feel when you make the differences.
And it's okay
the other thing about CT and MR, of course, is that MRI is magnetic, and it's looking at the magnetism in your body. You have to not have something that can't be in a magnet. So there are people that have either like shrapnel in the eyes or BBs. Those are terrible for MRIs. There are some things that really you can't have an MRI. Sometimes certain coils or parts from aneurysm surgery in the brain may be prohibitive from the older ones. The newer ones are usually fine. But it's important to know what metal is in your body. If you're not sure, they can do screening x-rays to tell, where they're actually looking for things that are ferromagnetic that can't go in the MRIs. So many things they can work with, many even pacemakers and ICDs they can work with, but not all of them. So if you can have an MRI, the MRI actually does not have the radiation that a CAT scan would have. It doesn't have any radiation. It is loud and clanking. It is, if you're claustrophobic, it can be a problem. It's longer. So if you have orthopedic issues, it can be more difficult. There can be sedation given if you need sedation to get through the MRI, but the risks are small. There also are new dyes that can be used with kidney disease. So kidney disease has always been an issue with the contrast dyes. The newer dyes can be used with any type of kidney disease. So that actually is very exciting for MR. For CT scan, there is radiation. It's generally low dose radiation. The newer scans are able to use lower doses. There are contrast dyes that are being used. They're iodine based. So if you have an iodine allergy, you need to be pre-medicated or you can't have the test. And you need to be pre-medicated 24 hours ahead of time. The contrast dye can affect the kidneys if you have significant kidney disease. So that's actually really important too. And those are some of the most important differences.
So even though CT is considered the gold standard, it is worth having the conversation with your doctor.
Yes, especially if you have kidney disease. Or if you've had a lot of CTs, or you're in a, again, a lot of the patients, even in the support group the other night, we heard someone say, well, I've had probably 15 CTs, in a year. And one of the questions is, well, could some of those be MRIs so that you limit some of the radiation?
Well, and you won't get those MRIs if you go to the emergency room. So if anybody had extra ER visits, that could contribute to those CTs too.
Absolutely.
Well, let's see if we've got some questions here.
Well, and the other option for people that can't have either that shouldn't be forgotten is transesophageal echo. So transesophageal echo is looking down the food tube at the aorta, which sits right on the food tube. It crosses right in front of it. And you can see the whole aorta in the chest that way. So, for example, in an emergency room, that is something that can be done as long as you haven't eaten. But it can also be done in somebody with kidney disease if they either can't have a CT and MRI is not available or it will take too long. But say you have advanced kidney disease and you're going in with crushing chest pain, and they don't want to do a CT with dye, or they do the regular CT and just can't tell, then you could do a transesophageal echo. It's another option.
Are you sedated for that?
You generally do get at least slightly sedated. Yeah, sort of like a colonoscopy type sedation.
Well, at least it's something.
Yes.
We do have a question for those of you that are watching. If you'd like to ask a question, just put it in the comments section below. If you'd like to remain anonymous, shoot Aortic Hope a message, and one of the team members who are watching right now, one of the board of directors, will go ahead and type that question in. on your behalf, and you'll stay anonymous and we'll answer it for you. So what about someone with a bicuspid valve that has a 4.5 ascending aortic aneurysm? What are your thoughts about that?
So the bicuspid valve is a really important question, and again, a different group of people. Mm-hmm. So bicuspid valve patients, often the aneurysms are a little bit more stable than they would be for like a vascular Ehlers-Danlos or Marfan's patient. Generally, the numbers recommended are around 5 to 5.5 for a patient with a bicuspid valve, or if it's expanding, about a 0.5 centimeter a year. Now, sometimes when people want to plan a pregnancy, we start looking at, what kind of numbers should we be using? It's known to, all aneurysms are known to potentially increase with the hormones that relax collagen, and also the stress of the pregnancy, all the extra volume that people are carrying. Some people recommend going down to as low as 4.8. But generally people stay around 5, even for somebody entering a pregnancy. Okay. 5.5 is where you absolutely have to do it, or the numbers are just too high for the risk of rupture or dissection for a bicuspid valve. You're also looking, in that case, at the function of the valve. Some people have valves that function normally. Sometimes the valve is actually leaky or tight. And if you need valve surgery, you may want to try to repair the valve and replace the aneurysm, repair the aneurysm at the same time.
So also I wanted to ask you a question about that. One of the things I thought was interesting is while aneurysms don't shrink, your valve, if you start off with aortic valve insufficiency at moderate, it could go down to mild. They can get better if you didn't have good blood pressure control. So how did those change, and what can contribute, and how can we help our valves be better?
So the aortic valve actually is the valve that separates the heart from the body's circulation. So when it's closed, it's got back pressure from the body under high pressure. So it basically, it's the diastolic blood pressure that's sitting on it. It's that bottom number on the blood pressure that we want to be 80 or less. Mm-hmm. When that number is 90, it's 90 millimeters of mercury pushing back on that valve. That's going to make the valve leak more. Okay. So it's pressure backwards. So if you have this valve that's a little weak and you take all the pressure off of it, it can function much better, right? So it can do much, much better. And you can definitely take a weak valve, change the blood pressure or the afterload, and have much better function. So the studies with the aortic valve, with the aortic insufficiency or a leaky valve, are really done with 2 drugs, nifedipine, which has also been translated to amlodipine, and the ACE or ARB classes. Those are the classes that have been shown to reduce the leak and increase the time to surgery for that valve. Okay. And that definitely holds for bicuspid valve patients. So we actually try to get medication on board if your blood pressure is high that unloads the valve and makes the afterload lower. Okay. So we try to get that diastolic down. Salt will bring that diastolic up. Low salt diet is really going to help.
Okay. And so that's the way that we can help save our valves a little bit.
Absolutely. Okay. And also, again, with aneurysm or dissection, we want aerobic activity. We don't want really heavy straining.
So nothing where you're holding your breath and bearing down.
Exactly. That really heavy straining is terrible for you. The isometric maneuver straining are bad. Aerobic stuff is great. You should be able to have sort of a short sentence through your activity. It's a good level.
So when people ask what are some of the things we can do, that's another area that's not 100% decided upon across the board in the medical community, but doing something aerobic is okay. Making that blood pressure and heart rate go up is okay, because you hope it's going to come back down.
Right, and it'll stay down lower than it was before.
Okay, so get up and move. Hence we have this Aortic Hope movement for the year. So we're trying to help everybody feel comfortable doing what they're told they can do. And even if you just move at some point during your day. These watches are great now because if you sit for too long, they will buzz you and tell you, I think you should get up and stretch. And then when you do, they make all kinds of noise and they get happy for you. So yeah, it's about, nice. Because not everybody can run a marathon or even walk a 5K. So any kind of movement is good. even you can do yoga. You just need to maybe be mindful of your body positions and not necessarily be downward dog for extended period of time or anything like that.
Well, the other thing about yoga is if you're hypermobile, if you're super flexible, you really want to do yoga to the point of normal stretchiness. Okay. Don't overextend, right?
Okay. So my son has mild dilation of his ascending aorta, Z-score of 3, and had this genetic testing result. It says MYH11 copy 3 uncertain variants.
So an uncertain variance is exactly that. So MYH11 can certainly be a gene, and it was tested because it's a gene that can be pathogenic for aortic dissection. And he was tested because he does have a larger aorta. So it's going to be really important to follow that. It's also going to be important to figure out who in the family might have aortic disease. And you could even, if you have another person that's living that has aortic disease, you could have them tested and try to figure out if this variant actually goes with the problem. And then you would understand it a lot better, like where it came from, and other people could be tested. However, a variant of unknown significance means that there's a spot on this gene that may or may not matter that's changed in this person. So just like fingerprints, where everybody has some unique individual aspects that may just be like hair color or eye color, they may not be something that actually, something that actually is causing disease. We don't want to act on something that is just interesting about your son. But at the same time, if you look at people that have a gene that's abnormal, their event rate and their disease rate is much, much higher. If you look at somebody who has a negative gene, their event rate and disease rate is remarkably lower. And if you look at somebody with a variant of unknown significance, for the most part, they run right in the middle of those event rates, meaning some of them are disease causing and some of them really are not. Okay. So we try not to overinterpret those. We try to follow them and see what's happening in other families as the testing gets extended, and try to decide, is this particular spot really important or not? So for example, your son will be in the gene company database at least, and as other families show up that are being tested, they'll look at, does this person have or not have disease with this variant, and how many people really have disease that have this variant. And they'll also start getting better understanding of the structure of that spot. What does the spot do? And if you change the spot, would it cause a problem, or would nothing really happen?
Okay, interesting.
So over time, you'll get a better understanding. But what you want to do is file that away, follow the aorta, make sure the blood pressure is good, that the lifestyles is good, try to have him keep his weight good, and, don't come out of doctor's care. I'm not sure how old he is, but as he's getting older, it may be important to give him the information so that he doesn't get lost to follow-up. So as people transition through adolescence into adulthood, that's really the danger zone. Right. Parents get older, the information gets lost. They say, I was followed, but nothing was ever really done, so now I'm okay, going off to college, and then I'm free. Right. And then they just never get followed up till they have a problem. So this is something that you want to share with your son as he's able to.
And let me ask you a real quick question about that before I forget. So when you've had your genetic testing, if everything has come back that there isn't anything, how long do you wait before you get tested again to see if there's anything new?
You should probably have that discussion with your doctor about every 2 to 3 years. Okay. And say, what's really different in the commercial panels? Okay. Or are there research panels I should be looking at? What is new in the testing and understanding of my disease? Okay. And when the answer is, well, when you had the testing, there were 6 genes, and now there's 24 genes.
Time to be retested.
Yep. Let's go ahead and look, and maybe it's worth doing it now. Okay. Or you could say, well, now we have this next-gen sequencing. But they're coming out with this, 2025 sequencing, and it's going to be remarkably different. And if you wait about a year and a half, we're going to have something totally different to offer. Then go ahead and get your family their echoes, or depending on what they need, get them done. check it off, wait that year and a half, and come back and say, okay, I'm ready for the 2025 power test.
Okay.
And I'd like to have it now. And that's a good thing. But put it on your calendar for a reminder to bring it back up. Just the conversation, what's different from when my panel was done.
Okay. If you have questions, now's the time to get them in, because we have about another 5 to 10 minutes and then we have to stop. But so to follow up on Christina with her son, would you recommend testing all members of the family or only ones with dilated aortas?
I would test all of Christina's children, her parents and the child's father's parents, and
herself.
Well, actually, herself and the father of the child.
Okay.
And whichever of those two carry that variant. Well, actually, you're not going to check for the variant. So unless somebody has an aneurysm, I would do the screening like a echo on both parents of the son. And then either family side that, if, for example, the mom has a dilated aorta, her side, if the dad has a dilated aorta, his side, if neither do, then I would test both of them again in 5 years.
Okay.
And I would certainly test all of the siblings of the son. And depending on the age of the son, his children.
That's true. We don't know what age. We don't know how old
Exactly.
anybody is. If someone has had genetic testing and a parent has bicuspid and an aneurysm, what should be looked at in the genetic testing?
So we don't really have good genetic testing for bicuspid. One of the things about bicuspid is it is about 5% of family members that actually will have it, and it can generation skip. So you could have a grandson or a cousin or something like that has a bicuspid valve, but it's not very commonly like parents and children or multiple siblings. So I would consider, first of all, a physical exam. Some people are comfortable that if the physical exam's normal, then you're done. I would go for the echo, especially before something like a pregnancy. This is also something that currently can be seen on prenatal testing. So if you have a prenatal echo, you'll know. So if you know, for example, that you have a bicuspid valve, but on your child's prenatal echo, they saw 3 leaflets, you're done. But it's something that can be visualized very easily on the echo. And again, it's 5% of family members, but we don't have genetic testing to look for.
Okay. Christina just said that I guess he's 8 years old. Brother is 12 with dilation, but genetic testing for brother was normal. So that's interesting.
Yeah, so the variant may not be the problem.
Yeah.
Right.
Okay. So it might not even be that gene. That's the issue.
Right.
And yet
and
you've
that's
got
why
2 brothers with dilation. So there's something there, but.
Right. And it's good that they check the other brother that has dilation. And again, it may be that variant is actually just a normal variant for this particular boy.
That's so interesting.
So
really
we try to, it's an irritating problem and it can be maddening, but we try to file it away and relook at it over time. And if there are other family members that are affected, again, you could check for that variant. And if it's not there, then it's not tracking with the aorta. So you don't want to make decisions about the aorta based on that gene. You want to actually do the echoes or testing. And
more about test results versus the gene.
Exactly, because you don't have confidence that you know that gene matters.
Okay. For someone who's had a dissection, is there a higher incident of concern for being under anesthesia? This comes up a lot because we have to get other types of procedures. It could be anything. It could be a hysterectomy, who knows? And there's concern about having anesthesia after a dissection.
So usually you want to wait, especially if it's elective, a minimum of like 3 to 6 months to recover, to let your liver recover, to let the anesthesia wear off, and that would lower your risk. The dissection itself does not have a risk. You want your blood pressure controlled, but you may have fragile vessels. And some of these conditions, the skin healing is difficult. So, for example, the vascular Ehlers-Danlos are known for kind of cigarette scar type burns, and you have to be very careful with the skin repair and the scarring. So it's very important to actually know what you have and what kind of precautions they may need to take to make sure that you heal properly. Somebody with a hernia, may actually, and a dissection may have Marfan's, may have something that makes the connective tissue around the hernia weak. And sometimes you actually favor using mesh because of that. Sometimes you're very careful around the vessels. So again, you want to look at what do they have? And again, if they have Marfan's, you want to look at the other side of where the hernia is.
I don't know if she's been tested, but what if she hasn't and now there's a hernia and she's had a dissection? I think it would be recommended to definitely be tested.
Right. But again,
yeah.
if she's had a dissection and she's young without atherosclerotic disease and bad, really bad blood pressure, she probably wants to be tested anyway.
Right.
I learned a lot recently from a patient of mine who is a lupus patient that had an aneurysm, had her entire arch replaced, and a couple years later on screening had a new aneurysm in the descending thoracic aorta. And we were looking at stenting, and we were having a conversation about why. Her lupus is pretty well controlled. It's bad, but it's pretty well controlled. Certainly aneurysms are, known to happen in lupus. She has a high ANA level. And, she said, look, I'm uncomfortable with this. I don't feel like this is all my lupus. So said, you know what, let's just do the genetic testing. This is reasonable. It's out of proportion. You have a daughter, you have parents, you have people that matter in your life. And she actually had a really serious FNLA mutation that her mom has, and her mom turned out to have an undiagnosed aneurysm.
Wow.
A very large thoracic aortic aneurysm that was repaired that never would have been found. And the life expectancy with that mutation is poor. And it's poor because people look completely normal. They don't have any other features, and they die early of aneurysm. Wow. So we're in our first generation where we actually are aware to look for these things and to preempt the problems that come up. Yeah. So that, she may end up with somewhat of a rebuilt aorta, but we expect her to do well and to survive. Right. Where, for example, her mom we never would have caught, and her daughter was negative for the gene. So
that's amazing.
It's amazing. So her question, saved her mom's life, and my sensitivity for doing the testing went way down, at least immediately, because it was her question that prompted the testing.
That's incredible. 14 months after a type A emergency dissection, had a fairly simple recovery, but still has a lot of chest and back pain. Also a dry cough, shortness of breath. Any ideas? I'm wondering if the dry cough could be the medication, maybe?
Could easily be the medication. So sometimes people get cough from things like the ACE inhibitors or angiotensin receptor blockers, like lisinopril, Prinavil, Ramipril, all of the prils, or sartans. So cough can come from that. You could also have just sort of an inflammatory reaction, or you could have a little fluid left over in the chest. So an x-ray might be very helpful. If there's amiodarone for rhythm issues, that can affect breathing. Scar tissue can certainly cause some discomfort. Cough, if you're coughing that hard, you could be pulling muscles. But it would be worth having that discussion for sure. And certainly either a CAT scan of the chest or an x-ray at a minimum to try to look for why you're coughing. The other thing that can happen with coughing is reflux. So certainly, this type of problem can stir up a lot of angst and a lot of stress. The surgery itself is hugely stressful on the body, and reflux can just take rage. So treating reflux can prevent cough, because when you're laying flat, you can get stomach acid that gets into the lungs and causes reflux or causes lung issues.
That definitely happened to me. It's been 5 years. So I find that when I lay down flat every night, it's been an issue. Sometimes I go on a medication and it reduces it, but a proton pump inhibitor, but then it goes away and then it comes back. So that's happened.
And you also want to do things like not eat too close to bedtime.
I try not to eat anymore past 5.
5 is early.
Yeah, 5:30. Well, tonight I'm kind of done. But all right, we're going to take our last couple questions here. Just that the hernia. She has LDS SMAD3.
So that's also why you have the hernia, and it's worth looking at both sides, so that if you're going to go under anesthesia and both sides are actually herniated, you could get both fixed at the same time. Okay. So with Loeys-Dietz syndrome, hernias are very, very common. And again, it's not the anesthesia that's so risky, but with low aesthetes, you also want to make sure your airway is good. Sometimes there's a very high arch, so you want to have the anesthesiologist actually look at the back of the mouth and throat before they start to make sure that you have a safe airway.
Okay. I had a dissection all the way down and my arch replaced in 15. Descending is measuring at 5.4. Surgeon recommends 5.5, even with having Marfan before doing surgery. Should he be proactive and just get it done now? The surgeon says ultimately it's up to him.
It's up to you, but those are big numbers with Marfans. And a lot of times with the descending, there may be an option through the catheter. So I'd also talk to the surgeon about catheter-based technology. Again, for example, this is a stent within here that they're covered stents that can go right through an aneurysm as long as there's no major branch that goes by it. For example, if there's a branch that goes to the spine, they can't just cover it. So, but there are some new technologies where some of the stented materials can be made to have a branch in them.
Wow. Okay.
So they can actually be created for you in something like this. So, so you're at a place that should have all of the technologies available. But this is definitely something you should be looking at. And again, with Marfans, it's a big number. So it may be worth re-talking to your surgeon. It's also worth looking at a time in your life that's a time that you're ready to go through it. Right?
Yeah. And being prepared.
Being prepared, having family support, having time off of work if you're working, but really getting your support in your life and your other challenges, organized that you can take a minute for yourself. So when you're hearing, yes, you're going to need it done in another millimeter, I would say look at when it's good in your life and just schedule a time.
If now in your life it's calm, it might just make sense.
Right. And also for many people, it's worse to feel like a ticking time bomb.
Yes.
Yeah.
I think
so that's a question.
That
so what is the risk of this spot? And what are you waiting for? And how does it feel to be waiting?
Those are good points.
So those are things that I would take into account. And those are personal things.
Okay. Well, we have made it to our 1 hour mark, even though we even started late. We did it.
I wish you all well.
Thank you so much. And if you have questions that you'd like to ask, if you're seeing this on a rebroadcast, when you come onto our site, just add your questions to the comments and I will get them over to Dr. Fisher and she'll be more than happy to answer them for you.
And for Mary with the asthma that's new, it really can be triggered by reflux. Treat that first.
Okay.
Yeah.
Sounds good. Thank you again so much.
You're very welcome.
I always learn something new.
Well, I always learn from you too.
I don't know how that's possible. Well, that's because I share with you all kinds of new things I'm feeling. So
exactly.
Yeah, well, thank you. And thank you. And we will see you soon. We'll get you on the next one next month. Oh, and don't forget, we're having our symposium April 4th in Baltimore, University of Maryland. If you can get here, you should get here. It's going to be really wonderful. We have Dr. Fisher speaking, 2 other doctors, a therapist, a head of pharmacology, and someone who works at a partner in a law firm to talk about SSDI, plus a survivor. And that evening, we have a free comedy show headlined by the survivor, Kristen Anderson. So check it out. You'll see the event listed in our event section on the website and on Facebook. We also have something very exciting launching tomorrow. So be online in the morning and you can be a part of it and get in on the fun stuff we have.
And I'll try to bring more 3D printed aortas.
Please, we'll have more stuff for you to touch and look at while you're here. So have a wonderful night. Thank you again. Take care.